All right, colleagues, let's talk about something we see every single day in our practice, the patient on a PPI. It's on almost every chart, right? But what does it actually mean for fracture healing? Is this common medication quietly sabotaging our work? That's what we're digging into today.
So picture this. It's a familiar scene. You have a patient, maybe with a few comorbidities, who comes in with a nasty tibial shaft fracture. You're getting them ready for an IM nail, and then you see it on the med list, omeprazole long term. And the big question hits you. Could this simple pill be a major roadblock to a solid union? Is this a risk factor we can actually do something about?
Okay, so before we jump into the clinical studies, we have to ask a fundamental question. Does this even make sense biologically? Is there a plausible reason a PPI could mess with bone healing? Let's get into the how, the potential mechanisms at play.
When you look at the research, it really boils down to three main ways this could be happening. And, these aren't isolated pathways. They probably all feed into each other. We're talking about everything from how we absorb minerals to direct hits on bone cells and even some wider metabolic curveballs. So let's unpack this a bit. First up, the obvious one, acid suppression. If you've got less stomach acid, you're just not going to absorb minerals like calcium and magnesium as well. Simple as that. Then, and this is maybe even more concerning for us, we've got lab studies showing that PPIs can directly mess with our osteoblasts and osteoclasts. The builders and the wrecking crew of bone remodeling. That can slow down the whole process. And on top of all that, you have these indirect hits like low magnesium and B12 levels, which just make for a really poor healing environment overall.
Okay, so the biological theory holds water. It's plausible. Now, let's see what the actual evidence says. We're going to start at the bench with the animal studies and then move to the bedside, where things, as we know, always get a bit messier.
And this is a really critical point we have to grasp. In the lab, with animal models, it's a pretty clean picture. You can control everything, and the signal comes through loud and clear. PPIs seem to slow things down. But when we look at human studies, well, it's more like listening to a staticky radio station. We hear a signal, an association with higher risk, but there's a lot of noise, a lot of potential confounders we have to account for.
The lab work is honestly pretty convincing. Study after study in rats and mice shows the same thing. Give them a PPI, and the fracture callus just doesn't have as much new bone. They've even seen it choke off angiogenesis, the new blood supply that's absolutely vital for healing. The bones are mechanically weaker, and get this, in some cases 5 weeks out, where you'd expect to see solid bone, you're seeing fibrous scar tissue instead. That's a classic sign of a healing process that's gone off the rails. But now let's turn to the human data, and this is where it gets tricky. We've known for a while from big meta-analyses that long-term PPI use is linked to a higher risk of fragility fractures in general. When you narrow the focus specifically to healing, you find some case control studies that point to higher non-union rates. But, and this is a big but, it's all observational data. And it's not a slam dunk. Not every study finds this link, especially in areas like spine fusion. So the picture is, well, it's a bit murky. So to try and get a clearer picture, I want to do a deep dive into one specific study that really tried to pin this down. It's from Fernandez Arayabe and his group back in 2021. And they looked right at the population we care about, patients with femur and tibia fractures. What they did was pretty smart. They used what's called a nested case control design. They found 56 patients who had their femur or tibia fixed, but unfortunately went on to a non-union. Then they did the hard work of finding 144 similar patients, same fracture, same age, same sex, who healed up just fine. These were their controls. And when they crunched the numbers, one finding just jumped off the page. If a patient was on a PPI, any PPI use, their odds of ending up back in the OR for a non-union were 4.5 times higher. Let that sink in. 4.5 times more likely to need another surgery.
But it gets even crazier. They looked closer and found what looks like a dose-response effect. For patients who are on a PPI for a prolonged period after surgery, that odds ratio didn't just go up, it skyrocketed to 12.3. 12.3. That's just a massive clinical signal. You can't ignore a number like that.
Even the authors were careful to say the strength of this association is notable. And they're right. No, this isn't a randomized trial. It doesn't prove causation. But a signal this powerful from a well-designed study, it absolutely forces us to stop and pay attention. Okay, so we've got this eye-popping number. But you and I both know we're trained to be skeptics, right? We have to look at any study with a critical eye. So let's take a step back and talk about the limitations here and try to keep a balanced view. First and foremost, this isn't an RCT. It shows a strong link, but it can't prove that the PPI caused the non-union. And we have to talk about the numbers. That crazy 12.3 odds ratio, it was based on a pretty small number of patients who needed surgery, just 12. That means the real number could be a lot different. The confidence intervals are wide. And of course, there's the classic problem, confounding. Maybe the patients on PPIs are just sicker to begin with, and that's the real reason they didn't heal well. So where does that leave us? Here's the bottom line. The basic science is pretty consistent. In the lab, PPIs look bad for bone healing. In the clinic, we have a growing body of evidence that suggests there's a real association with non-union. But it's all observational. The one thing we're really missing, the holy grail, is a big, well-done, randomized controlled trial to settle this once and for all. But we can't wait for that perfect level 1 study. We've got a patient in the ED right now or on our table tomorrow. We have to make a decision today. So how do we take all this information and turn it into something we can actually use in our practice? I think we can boil it down to a simple 3-step plan for any fracture patient on a PPI. Just remember, review, optimize, and discuss. Let me walk you through what that means.
Okay, step 1, review. Ask the hard question, does this patient really need to be on this PPI right now long term? Work with their primary care doc. Can we deprescribe it? Can we at least lower the dose? Step 2, optimize. Let's give the bone everything it needs to heal. That means making sure their calcium, vitamin D, magnesium, and B12 are all topped up. And obviously, if they have osteoporosis, we need to be treating it aggressively. And finally, step 3, discuss. Especially in a high-risk patient, a smoker, a diabetic, someone with a nasty open fracture, we need to have a conversation. Talk about the potential risks and benefits of stopping the PPI, maybe switching to an H2 blocker, and balance that against why they were on it in the first place.
So I'll leave you with this question to think about in your own practice. With all this evidence piling up, the solid lab data, and this really concerning clinical signal, shouldn't a formal PPI review be a standard part of our checklist for every single major fracture we treat? Is it time we made this a routine step? Thank you for your time.